Мозес, директор отделения клинической микробиологии инфекционных заболеваний, университетская клиника Хадасса, город Иерусалим. Профессор Алон Мозес является ведущим специалистом Израиля по инфекционным заболеваниям. Он рецензент грантов от Израильской академии наук, Германо-Израильского фонда, научного факультета о здоровье университета Бен-Гурион. Please.
Thank you very much. Cannot speak in Russian, sorry. And I have a lot to show. I have to decide between speaking quickly, which is how I'm used to, so that I can finish everything, and speaking slowly so that the translation can work. So I promise you that at the very important places I'm going to slow down. So I'm going to speak about infection control principles and practice. Before I do that, I want to tell you a little bit about my department. I'm head of the department which is called the Department of Clinical Microbiology and Infectious Diseases, where together in one department, the infectious diseases, as you see on the right, the clinical microbiology lab and the clinical virology lab. If you look under the infectious diseases, we have a very strong infection control group, and the infection control is what I'm going to speak about. But as you will see, infection control really is a question of resistant bacteria and transferring resistant bacteria from one patient to the other. So the fact that the lab is together in one department is very helpful, and I'll give a few examples of that. For the past 10 years, our hospital, Hadassah, has given a lot of effort into infection control. So we now have a doctor who's in charge of infection control. We now have 6 or 7 nurses in our hospital who do only infection control. And as you will see, infection control, which used to be, something that people practice without very clear guidelines, now is practiced by very specific guidelines, and I will try to show some of these. So there's a common perceptive that when a patient goes into the hospital, he's getting good care, he's going to be cured, he's going to be treated. But unfortunately, this is not always true. And as I will show, sometimes going into the hospital actually it gets the patient into trouble. And it's been shown many times by the World Health Organization and now by many people all over the world that healthcare associated infections, HAI, are a major problem for patient safety. And we will see that this problem is not a small problem. We now know that healthcare associated infections prolong hospital stay. They cause long-term disability to patients. There's increased resistance to antimicrobials, and it's a very big financial burden, and I will show that the cost of resistant infections and hospital-acquired infections has been well documented. But not only these are only money, also patient death, there's no question about that. We now know that about 10% of patients who are admitted to the hospital will have a hospital-acquired infection, sometimes called healthcare-associated infections. We also know that 70% of all hospital-acquired infections are caused by resistant bacteria. These are the numbers in the USA, many patients per year. The mortality is 25,000 per year. In Israel, we know that the mortality, the calculated mortality for infectious diseases the patient got in the hospital is 10 times more than the mortality from road accidents. So this is something that must be taken into real consideration. When we speak about hospital-acquired infections, it really consists of two parts. The resistant bacteria, and resistant bacteria are gram-negatives, Acinetobacter, carbapenem-resistant Klebsiella, and other gram-negatives. The gram-positives, which are vancomycin-resistant Enterococcus, and everybody knows about the resistant Staphylococcus MRSA. Clostridium difficile, which causes hospital diarrhea, and we must not forget tuberculosis. All over the world, I think that in your country it's a substantial factor that has to be taken into account. This, did I call? Okay. I often lecture in Ethiopia. We have a very good collaboration with Africa, and there all of a sudden there's no electricity, and you have to give the lecture without the computer, and I say it's like playing chess without a board. You have to learn how to do it. So one side is the resistant bacteria, the other is the acquired infections. What are the infections that the patient can get? He can get a surgical site infection, he can get a line infection if he has a central line, and I will show you what we do about these. He can get a pneumonia from the ventilator, and he can get a urinary tract infection. Are these all the infections? No, these are most. He can also have a bed sore. And other infections. So how can we prevent cross-infection? First of all, we want to prevent the transfer of bacteria from one patient to the other. I will show you that this is done mostly by us. The nurses and the doctors, we touch one patient, we go to the other patient, so if he has resistant bacteria on his skin or in his surroundings, and we don't do the things we have to do, we will transfer from one patient to the other. We have to know that resistant bacteria do not develop in de novo, but there's a system, and I will show you how they develop. We have to know that there's what we call colonization pressure. If the bacteria, the sensitive bacteria are treated with antibiotics, then the resistant bacteria remain. We have to know that the patient environment is full of the bacteria. If a patient is lying in bed, he is not always has a function of his stool. He has feces in the bed, so the bacteria can be everywhere, on the sheets, on the table next to him, and we talk about the patient environment as a source for resistant bacteria. But we have to remember that since the bacteria are in the surroundings, they can be on our coat, they can be on our tie, so we suggest not to go to a patient with a tie, but it can be also on all our medical equipment. We also have to remember that sometimes we see a patient with a resistant bacteria in a blood culture or in a urine culture or in a sputum culture. We call these isolates of resistant bacteria clinical isolates because they cause disease. But this is only the tip of the iceberg. The iceberg is the carriage of resistant bacteria. And we know that once a patient receives antibiotics, there's a change in the flora of his bacteria in the bowel, and from sensitive bacteria he is now harboring, he now has very resistant bacteria, and this is the iceberg itself. We speak about multi-drug resistant organisms, Acinetobacter, Clostridium difficile, Pseudomonas resistant to carbapenems, etc. And we mustn't forget, as I said before, tuberculosis. Tuberculosis has become more and more resistant, and we now speak not only of multi-drug resistant, so-called MDR, but XDR, the extra resistant tuberculosis, which is resistant to all antimicrobials. The Infectious Disease Society of America declared many years ago that the resistant bacteria are rising on the one hand, and the new antibiotics made by pharmaceutical companies are going down. And they call this bad bugs, no drugs. And actually, if you look at the new drugs coming out against resistant gram-negatives, there have been none in the past 10 years. We have new antivirals against HIV, we have new antifungals, but we have no antibacterials, nothing new against gram-negatives. Maybe in the past 2 or 3 years, they are beginning to develop one or two, but we're still far from being able to use them. So we must put our mind into thinking how we can stop the development of resistant bacteria. So we ask a question: if resistant bacteria increase, is it really because of what we do, or can we prevent it? So there's no question that if we use antibiotics, we increase the number of resistant bacteria. How do the resistant bacteria become resistant? If you look here, we have a patient with many bacteria. These are the sensitive bacteria, and this one is the resistant. The resistant bacteria forms by genetic mutation. There's a rate of genetic mutation of approximately 1 to 10 to the 7th. Bacteria can have a spontaneous mutation which causes it to be resistant. Now, if we treat patients with antibiotics, which are this, you don't see it. Okay, I have a notification. Something happened. Someone who reads Russia needs to look at this because I don't know if to press this or not. I need some help here.
Кто-нибудь может помочь?
This one? Yes. All right, thank you. So we give the patient antibiotics, the sensitive bacteria disappear, and this makes space for the resistant bacteria. The resistant bacteria are growing. This is how it happens. So it's not that the antibiotics cause the mutation. The mutation is spontaneous, but if we treat the susceptible, the sensitive bacteria, remain the resistant bacteria. My head of infection control unit in the department is a previous Israeli Air Force pilot. And he likes to bring this example. You can see here the rate of accidents in the big airlines. This is the airline. This is the number of flights, 4.7 million flights. The accidents or events which happen are approximately 3 to 5 million. We have to ask ourselves why in the hospital the events are approximately sometimes up to 10%. Up to 10% of our patients become infected. Why can we not be like the cosmonaut that was here, very precise, like the airlines who are working so that there is a minimal number of accidents? I think that the task is possible, and we sometimes have to think that we can prevent infections if we have a zero tolerance for infections, and I will tell you how we can do that. So we have to realize that a lot of effort has to be put into protecting our patients against infections in the hospital. Is it possible to prevent infections? It's been very clearly shown that 50% of hospital-acquired infections are preventable. Okay, so we need to prevent transfer, and we have a set of rules which I will go through, and I will try to, probably many of you know these. Hand hygiene is very important. Standard precautions, how do we treat a patient, any patient, not specifically a patient who has resistant bacteria. These are called standard precautions. Contact precautions are the precautions we put to a patient who has some kind of resistant bacteria or an open wound. And we do sometimes decolonization to a patient. And actually, if you look at one of the best ways to prevent transfer of resistant bacteria from one patient to the other, it's through hand hygiene. And now there are a set of rules about when we should do hand hygiene. It's very clear that you should wash your hands with a specific alcohol rub, and I'll show it to you in a minute, not only after you touch the patient, but also before you touch the patient. Because when you enter the room, if you touch the door, if you touch the computer in the other room, there's a chance that there are bacteria on your hands. If you try to show the bacteria with fluorescent staining, you can see that your hands are full of bacteria. So you have to clean your hands before you touch the patient and after you touch the patient. There are two ways of doing this. One is with an alcohol rub on dry hands, and the other is water with an antibacterial soap. A regular soap doesn't do it, and this very old paper shows that the best way to bring down the number of bacteria, this is the number of bacteria, this is with an alcoholic solution, so you bring down 99.9% of the bacteria. This is an antibacterial soap, and this is a regular soap. So if you want to bring down the bacteria, a regular soap really doesn't do it. Hand hygiene begins at the beginning of the shift. If you come out of your car, if you needed, to touch something, your hands are dirty, you need to wash your hands with chlorhexidine, 4% chlorhexidine-based soap. This cleans your hand and disinfects them. This takes about 3 to 4 minutes. It takes a long time, but you do this at the beginning. I'm missing the next slide. The next slide shows that with the alcohol rub, you take 1 or 2 mLs of the alcohol solution in your hands, and you rub your hands very thoroughly until they dry. When they dry, the process of drying, actually the evaporation of the alcohol kills the bacteria, and when your hands are dry, they are actually almost sterile. You will not find bacteria. This takes about 20 to 30 seconds. So we prefer that in every room there's an alcohol-based rub, and this is actually the rules of the WHO and the CDC and all the important regulatory places that you have to use an alcohol rub regularly. We have in our hospital specific signs for the different kind of isolation. This, for example, is respiratory isolation. This is droplet isolation. This just reminds you to wash your hands, and we give the families of our patients instructions how they should act according to the rules. Central line associated infections are a big problem in the hospital, and every personnel who is going to perform insertion of central line central lines in the hospital needs to do a teaching and learning program which we have on our intranet, and it's compulsory, as is hand hygiene. So anyone who starts working in the hospital does a hand hygiene program, and anyone who's going to have to work with the central lines needs to do the central line. In every room we have at the entrance hand hygiene, which we actually make at our hospital, and a sign saying that you must wash your hands. In the past, we didn't have on our beds any hand hygiene, and now when you look at every bed, there's a bottle, and this makes it very easy for the nurses and doctors to wash their hands when they're close to the patients. You have to remember that the one side of resistant bacteria is the use of antibiotics. So we have a very strong control of use of antibiotics. There are only a small number of antibiotics that the doctors in the hospital can use without getting permission from the infectious disease department. If you look at any one day in a hospital, about 50% of the patients receive antibiotics. And I must tell you that when I go into depth and look whether all of them need, approximately 50% do not need the antibiotics. If you look at any one day in the intensive care units, you can sometimes see that 100% of the patients are on antibiotics. So it's a big problem. This is causes, like I showed before, selective pressure. And we have a saying that when you use antibiotics, you lose them. When you use it, you lose it. This saying is just a biology. When you look at 1940, when penicillin was discovered, very early after the beginning of using penicillin, there was resistance to penicillin. So the bugs, the bacteria, very quickly become resistant to antibiotics, and therefore, when you use antibiotic, you lose them. You must realize, we must understand that if we give antibiotics, we have to give them only when it's necessary. If we give antibiotics when it's not necessary, for example, for a viral infection, for example, we give antibiotics for too long. For example, we have a very sensitive bacteria, pneumococcus, for example, which is susceptible, sensitive to penicillin, and we give something very broad. We have to give specific antibiotics for a short time and not to give when it's not necessary. This is a study we did at one time at Hadassah to show whether antibiotic prophylaxis is given correctly before surgery. And we showed these are inappropriate. It was in about 10%. When it was not needed, in about 25%. Not given on time, it was about 40%. Some were too early, some were too late. And too long was about 50%. 50% of patients received antibiotics for too long. They're very clear. There are very clear guidelines as to when antibiotics, how long they should be given. And all in all, 64% of antibiotics were given incorrectly to the patient who's going to have surgery. How did we solve this? We worked on it and decided that the only way to solve it is that the anesthetist is going to give the antibiotics. The antibiotics will not be given when the patient is in the department waiting to be brought down to surgery by the nurse, because then it's given too early. And by now we've shown that 98% of the time antibiotics are given in the correct way. I'm going to skip this. So what are the strategies for infection control? As I showed before, hospital-acquired infections are, on the one side, resistant bacteria, on the other side, the acquired infections. So how do we prevent these infections? There are basic rules, and there are bundles which tells you how to react to prevent each of the infections. The basic rules are standard precautions. For example, you go to a patient, you wash your hands. Isolation precautions. If the patient has an open wound or resistant bacteria, you go to him, you wash your hands, you put on gloves and a gown. We do cleaning and disinfection, and I will talk about cleaning. It's a major, of major importance, and we put a lot of effort into cleaning, and I already told you about antibiotic use. The bundles are bundles which we tell you how to, for example, with a central line bundle, how to insert a central line and how to maintain it. And I will show, and each of these infections in the hospital has guidelines, what we call bundle, how we should act to prevent the infections. So for example, ventilated-associated pneumonia, the bundle is very simple. You have to use hand hygiene when you go to the patient. The patient's head should be raised to 30 up to 45%. You should prevent peptic ulcer by appropriate medications. You should always think whether you actually need to give sedation to the patient, and every day ask the question, can we extubate the patient? Does he really need to be intubated? The question of whether he needs to be intubated is a question that you have to ask about many procedures. Does the patient need to have a central line? Does the patient need to have a urinary catheter line? Does the patient need to have antibiotics? All these questions are really in the heart of taking care of our patients. If we ask these questions, does he really need antibiotics? Then after 2 or 3 days, maybe we can realize that he doesn't. Does he really need a central line? You have to ask these questions, and they have to be part of your daily routine. Oral hygiene has also been shown, cleaning the mouth with chlorhexidine 0.5%, shown to decrease the number of bacteria in the oral cavity and therefore decrease the number of ventilator-associated infections. So you have to also measure the compliance. This is a list of many things that need to be done, but you have to ask yourself if the team is doing what they need to do. Okay, I want to tell you a little bit about bloodstream-associated infection and how we try to prevent it. Bloodstream-associated infection in the US are a big problem. Many cases, a high price, and even we know that it's possible to lower the rate of central line-associated bloodstream infections. About 12 years ago, one of a very interesting doctor by the name of Peter Pronovost did an intervention in a setting of many intensive care hospitals in the Chicago area. And he showed in a paper that was published in the New England Journal of Medicine that it's possible to decrease catheter-associated bloodstream infections. What was his secret? And there were many, many intensive cares involved in it. Hand hygiene, we spoke about. Maximal barrier precautions means that when you insert a central line, you need to dress as though you're going into a surgery. You have to have a sterile area to put on sterile clothes. You have to clean the skin with chlorhexidine. It was shown that if you clean it with iodine, it's not good enough. It has to be chlorhexidine. You have to avoid the femoral site because that's a place where infections are increased. You have to use a checklist when you insert, and you have to always ask if you can remove, as I said before. So the principles of prevention of CLABSI, which is central line-associated bloodstream infection, there is an insertion bundle, how do you insert it? There's a maintenance bundle, and surveillance. You do a surveillance of how many bloodstream infections you have. So the insertion bundle I spoke about, but I want to tell you about this. maximal barrier precautions and empowerment. What does the empowerment mean? It means that whenever there's an insertion of a central line, there's a nurse who's standing on the side, and if she sees that the guidelines have been breached, if they are not done in the correct way, she can stop and say, do not insert, you have to start from the beginning. This empowerment is part of being able to lower the number of central line associated bloodstream infections. This is how you need to maintain, you clean the insertion site with chlorhexidine, hand hygiene, and again, daily review of is the line necessary. Surveillance, you have to see if the checklist is done, and you have to measure the number of central line associated infections per 1,000 catheter days. And then you can come to the department and say, look, you have this number of infections, you're much more than the others, and I'll show you what we do at Hadassah. Through this procedure, Pronovost, and this is from his paper, was able to show that the baseline infections were 7.7 per 1,000 catheter days, and they were able to lower them to 1.2, and 60% were able to keep these for at least 12 months, and in a follow-up paper 3 years later, he showed that most intensive care units were able to keep this number for 3 years afterwards, even though they were not in the study anymore. So now there are guidelines for how to treat catheter-related infections. Our Ministry of Health already in 2011 put out guidelines how to do this. And let me show you in a few slides how we do it at Hadassah. So we have a program for lowering central line associated bloodstream infections for the past 4 or 5 years. Every month there's a file like this that we give all our intensive care units. We have at Hadassah 11 intensive care units. This is a report for June, for the end of June 2018. Every month, for example, the first line is the neurosurgical intensive care unit, the number of bloodstream infections they had, the number of central line associated bloodstreams they had, the number of catheter days, and here at the end you see how many since 2000 and the beginning, this should be 2018, 180 days they have no bloodstream infections. So this is a very good intensive care unit. This is less good, this is the general intensive care unit, 2.6, etc. So every intensive care unit gets a list of how many infections they had in the past month, and there's a monthly meeting of the intensive cares. We sit together and we discuss this, and this is how we do it. The previous one was from our hospital in Kerem. This is from the Mount Scopus Hospital. And we have graphs which we give every few months. I won't go into this. Now let me tell you about the very resistant Klebsiella. I must tell you that already 10 years ago, we noticed that there's a very resistant Klebsiella. But before I show you, I want to remind you that Klebsiella pneumoniae is a gram-negative organism. When penicillins were discovered, they were not effective against Klebsiella, neither was ampicillin, which was discovered in the 50s. Only the first generation cephalosporins was effective, but very quickly it became resistant. And then the humans developed the second generation, the third, and the fourth generation cephalosporins. In 1984, the extended spectrum beta-lactamase, which is an enzyme able to destroy all of these antibiotics. The carbapenems were discovered in the mid-80s, and in 2001 in the United States for the first time, it was shown that there's a carbapenem-resistant Klebsiella pneumonia, meaning it's resistant to all antibiotics. And in Israel, we noticed in 2006, we had a meeting from the Infectious Disease Society of Israel, and we showed that there, in the big center in Israel, it was a major problem. Since then, since 2006, we have changed our ways of treating resistant bacteria. And what I told you about the special unit that we have, a special doctor, all the nurses, this is a response to the 2006 outbreak of the very resistant bacteria. Now, we've been talking about resistant bacteria for many years. In 2006, that was the first one. And I have to tell you that in the past 2 years, and more in the past 6 months, we've been seeing patients dying with infections by bacteria which have no antibiotics. How long do I have still? This is an example. In 2013, Klebsiella pneumonia, resistant to all antibiotics. Nothing. Resistant. And unfortunately, this has become more and more, not only in our hospital, but all around the country, in many places in the world. And the only way we can fight this is by prevention of infections, by prevention of resistant bacteria. We now have a system where we follow monthly the infections, and I won't go into the details, but in the beginning we put patients in a single room trying to solve the problem. And then we put all patients with the resistant bacteria in one department. We call this cohorting. So from all the hospital, we take the patients with the very resistant bacteria and put them in one area, in a few rooms. That didn't solve the problem. In fact, at one time when we moved to our new building, the cohorting was stopped in the surgical department because they thought we're moving to this new building, there was only 1 or 2 patients in a room, maybe we don't need to put patients together with the highly resistant bacteria, but that only caused an increase in the number of our resistant bacteria. And now we have a monthly report. You see, this is the number of, now we call it CPE, which is carbapenemase producing Enterobacteriaceae. So that is the Klebsiella. It's not only Klebsiella now, it's also E. coli and other gram-negatives. So until in 2018, you can see the different departments and how many patients acquired the infection. At the top of the list is hemato-oncology and others. But the idea is that we report it all the time, and only if we report it like this do the doctors and nurses know where they stand. Our biggest intervention is that we put the patients together. We gave dedicated nurses to the patients with a resistant bacteria, which means that if we have a patient, a room with patients with resistant bacteria, we do not allow nurses to treat those patients and then treat other patients. These are dedicated patients. We also do a lot of cleaning. Now, the cleaning in our hospital has gone through a major change. We know that all the efforts we did were not enough until we put all our efforts into cleaning. We had to change the company which cleaned our hospital. In the past, we had workers in the hospital who would clean, and they were part of the regular staff. And then, because of financial reasons, the cleaning was given to an outside company. And we saw that the dedication of cleaning from outside company was much less good. There was a frequent change in workers. They would come for a few weeks until they learned how to work. They already were changed. We know that infection control has been described to be part of the architecture system. The planning, design, and constructions of new buildings has to be done according to rules. The JCI, yesterday we heard a long lecture about the JCI, shows that there's planning, design, and construction. The last edition is just in July, and it's written by the American Institute of Architects, so we have specific rules of how the place should be built. We also have rules. There's a big chapter about, infection control, designing for infection control, so you can read exactly what needs to be done, where a sink should be placed, what is the distance that needs to be between beds in an intensive care, etc. So the rules are very clear and we have to abide by them. This is from Ireland, this is from the CDC, and this is from California. So the goals of infection control are prevention of cross-infection, prevention of acquired infections, and the prudent use of antibiotics. I'm going to, just a few more slides. So the way to really affect infections and to have the best infection control is to have zero tolerance. We are not willing to accept someone who does not wash his hands. We are not willing to accept, and this has to come from the top of the administration, the top of the hospital, to the person who is cleaning the room. If we do not abide by these rules, we cannot make a change. Nowadays, we have a hospital committee for infection control. The head of the committee is the head of the hospital. He is the leader. The support is given by him to everybody else. The year 2018 at Hadassah has been declared infection control year. We give constant reports on the incidence of the carbapenemase producing Enterobacteriaceae. We follow the numbers of Clostridium difficile infections, and we've been able to show that there is a decrease in the past year in one hospital, and this is in the other hospital in Mount Scopus. We put a lot of effort, as I said, into environmental cleaning, and we change staffs. We actually check the number of spots which were cleaned. So when we have a room that needs to be cleaned, our nurse comes in and puts fluorescent color in many places in the room, and after the cleaner cleans, she comes back and sees where they are left. Now, she's not putting the fluorescent material in hidden places, in very obvious places that should be cleaned. And in the beginning, when we did this, only 58% of the spots were cleaned. This we started in January. As you can see, we are slowly improving, and in June already 85% of the spots were cleaned. But believe me, this is through a lot of effort. We bought now a new machine which is giving UV ultraviolet light to the rooms after the patient has left. And this is part of the 2018 infection control year. We put a lot of effort and put posters all over the hospital. We must remember that infection control is teamwork. It cannot be done by one person. It cannot be done by a small group of persons. It has to come from the top to the bottom. And we say that infection control, this is in Hebrew, infection control at Hadassah is in our hands. Thank you.
Thank you very much, Professor Moses. It's very interesting topic. Please, questions to Professor Moses. Пожалуйста, вопросы.
Спасибо огромное, очень интересное сообщение. У меня, если позволите, несколько вопросов. Первый, скажите, пожалуйста, известны ли случаи устойчивости микробов к хлоргексидину? Второй вопрос, ну или по очереди.
My guess is you asked if there are resistance to chlorhexidine, but I'm not sure. Is that the question?
It's the question, yeah.
Okay, so see, sometimes one word is enough. There is occasional resistance.
Just a moment, please.
Просят в микрофон говорить.
Yeah. Okay, there is occasional resistance to chlorhexidine, but it's very rare, very rare. There are some specific bacteria which can grow in the environment. Therefore, we usually want to change, not to leave a bottle open for a long time so that, for example, Pseudomonas can grow. But it's a very unusual event. Much more resistance to antibiotic than to chlorhexidine.
Спасибо. Второй вопрос. Скажите, пожалуйста, как быстро вы получаете ответ микробиологической лаборатории у пациентов, которых вы принимаете в больницу? Вы говорите, что вы их переводите сразу в какие-то отделения.
Something about the lab.
Yes, okay. The question is how fast you realize the flora of the patient, and does the patient who is really infected with the resistant bacteria could be transported to the isolated.
That's a very good question. You have no idea how much effort we put into giving an answer within 24 hours. The patient comes in to the emergency room. If we suspect that he has a resistant bacteria, we take a culture from his stool. The next day, if it's growing, we do a PCR on it to identify the resistance genes. So within 24 hours. And in the middle, until then, we put him in part isolation, and only then we decided to put him in the cohorting. You have no idea how much effort we put into it. A lot of manpower and a lot of struggle.
И мой заключительный вопрос. Скажите, пожалуйста, в одном из последних слайдов перевод никак, да? В одном из последних слайдов вы показали, что вы опять применяете ультрафиолет для очистки помещений. Насколько мне известно, с 90-х годов в европейских больницах ультрафиолет уже не применяется для дезинфекции. Это возврат к хорошо забытому старому или это какая-то новая технология? Спасибо большое.
The question is concerning ultraviolet. Is it the antic device which is implemented nowadays, or it's something new era of the
ultraviolet? Okay, we used to have ultraviolet in the microbiology lab, for example. These were small lamps, hanging up on the wall. And the problem was that their effect was only about half a meter, so they were no good. These new machines, after the patient leaves, can you show the slide? After the patient leaves, you put the machines, they're very strong. you put these two machines into the room, and they work for about 15 minutes, and we have shown, we put bacteria all around, and we have shown that after the room goes through the UV light, the bacteria are dead. So we've shown that it's very effective. There are about 3 or 4 companies in the world which make these machines, and we are just in the midst of deciding which ones to buy. But each one of these has gone through regulation approved by the FDA and CE, so it's not just machines that we buy from China or something. Excuse me, the Chinese.
I'm sorry, I have one question.
Yes.
Thank you for the interesting information. And infection control, it is a very important problem all over the world. In Israel, in Russia, in America, it doesn't matter. And I have a question. You told that in your department you have doctors and nurses. What is the responsibility of our nurses? Is it their special education? Is it their special responsibility? What they can do? What they can work?
I can talk for an hour about their responsibility. There is a list of things, from seeing that patients, we go and look in the department if the doctors wash their hands, and we write notes. We collect information about resistant bacteria. If there's an outbreak of infection, for example, after prosthetic biopsy, we had an outbreak of infection, so they go into the infection. We have 6 nurses. They are the most, the deputy head of the hospital is here. They are the most dedicated workers in the hospital. The head of our infection control nurses comes to work at 6:30 in the morning and leaves at 6:30 or 7 in the evening. Many, many things. I'll gladly talk to you about it.
Thanks.
Hello, thank you for it's a very useful topic for us, and have maybe 3 short questions. And for the first, you told that if you suspect some kind of antibiotic resist microbes in a patient, you use a PCR for identify them. Yes. So you're looking for certain. So you suspect just certain microbes. And did you use some multi-tool spectrometry or mass spectrometry in feces to identify the microbes, or just PCR?
Okay, so first if you want to identify the resistant bacteria, there are several ways. One, we put them on a selective agar, which has antibiotics, and only the resistant bacteria will grow. That's the first stage. The next stage, tomorrow morning, if we have the resistant bacteria, we know we want to identify exactly. If we want to identify those genes, there are a few genes for the resistance to carbapenemase, we are doing PCR. We also have Malditov, which is able to identify, it's a mass spectrometer system, identify bacteria to the species, but it doesn't tell you about resistance. It's not able to tell you if the resistant genes are there. So we work with several methods.
Okay, you tell us that you just use chlorhexidine. In Russia, we have a protocol in which almost once at 3 months or 1.5 years, we should change the antiseptic in a hospital. We have this protocol. Did you use this, or you just use chlorhexidine as an antimicrobial fluid?
I heard about this protocol that you have. I must tell you that we do not use this, and I'm interested to read more about it. I have not found that this was actually necessary. There's so little resistance. For example, the cleaning that we use for the rooms is chlorine, 1,000 ppm or up to 5,000 ppm, depending on the type of bacteria, and we've not needed to change it. So we use the same detergents all the time.
It's well information. Thank you. And the last question, your laboratory, as I understand, you work in a hospital, and did you use some kind of a centralization? So did you use your laboratory, do you use your laboratory to the other hospitals? Or somebody maybe brings you some containers?
Yeah, we are a relatively big laboratory. We provide services for another hospital, total services. We also give support, for PCR that we do on a regular basis to others who need it. In Israel, there's also a central laboratory, and we have a national infection control team which gives support to the 25 big hospitals in Israel. So the system in the past 10 years, since 2006, has substantially grown, and a lot of effort is put. For example, the Ministry of Health is giving money, support, to hospitals which abide by the rules of infection control. So we are hoping like this to lower the number of problems we have.
Thank you very much. Thank you, Professor Moses. Наши аплодисменты нашим спикерам. Коллеги, наш следующий докладчик доктор Нурит Порат, начальник отдела обеспечения качества и безопасности, университетская клиника Хадасса, город Иерусалим. Доктор Нурит Порат ведет научно-исследовательскую деятельность в области качества и безопасности медицинской помощи. Она является членом институциональных комитетов и национальных форумов Хадассы, целью которых является повышение качества и безопасности медицинской помощи. Тема доклада «Приоритет клиники Хадасса» – это безопасность пациентов.
Hello, I am happy, I am Nurit, and I am happy and excited to be with you. Okay, I also will speak in English. Okay, I also speak in English. Try to do it slowly and as much the time I have. So I will present points of organizational aspects regarding management of quality and safety in Hadassah hospitals. In the picture you can see the both Hadassah campus, medical hospitals. On the left is Hadassah Mount Scopus, in the right it's Hadassah in Karen. Okay. Quality and safety are one of the core activities of Hadassah hospitals. Our mission is and commitment is to provide optimal safety and quality care to patients, families, and our employees. I choose to present in shortly some examples of those activities. We can see that the activity domains of the quality and safety department are quality, safety, service and patient experience, organizational learning, and accreditation, JCI accreditation. This presentation focused on those issues. Our safety and quality activity focus to ensure and promote the 6 aims of quality health care, which were defined by the Institute of Medicine in the United States. We mean that we have to give safety care, effective care, timely, efficient, equitable, and patient-centered. The activity is both top-down and bottom-up. Top-down is the organizational annual work plan which every department director is committed to perform. One example is the demands to assimilate the performance of hand hygiene by every employee in every clinical unit. That is, every employee obliged to perform hand hygiene educational software and pass a test of this subject. The management of the hospital defines the departmental quality safety plan, but the unit managers have the flexibility to select part of the subject relevant to the specific department. Bottom up, here are some examples of top-down departmental work plan. You can see that every department has to carry out departmental quality or safety project, to define the clinical indicator and to assimilate it, to perform 3 debriefings of near miss or adverse event, to carry out a departmental plan for preventing infections, or to carry out a departmental plan for improving patient experience, to carry out a departmental plan for preventing patients' falls, and to conducting 4 staff meetings dedicated to safety instructions of subjects relevant to the department, and to assimilate 4 organizational procedures relevant to the department. Bottom-up refer to quality and safety improvement actions initiated and promoted by the departmental director and his staff. This is derived from the conception that the people who are engaged in an activity on a day-to-day basis know this activity better than anyone else. For example, quality project to improve the rate of patients receiving antithrombotic treatment prior to urology, laparoscopy, surgery, or improving the rate of patients receiving adequate preventive antibiotic treatment before pacemaker transplant procedures. Now I present the main quality activities. Here you can see on the left the quality domain. In the area of quality, we manage the National Quality Indicators project at Hadassah, which includes 60 national quality indicators. We manage the preparation of the hospital prior to Ministry of Health MOH quality audit and surveys. The dates of these audits are not known at the beginning of each year, and we are required to be prepared to them according to the MOH schedule. We develop organizational and departmental indicators. We carried out internal survey and audit in variety of quality and safety areas. For example, patient readiness for invasive procedures in electrophysiology or eyesight after cataract surgery. Inner survey and audit are, for example, informed consents of patients receiving blood, record control, patient education, and informed consents of radioactive iodine treatment. And we're promoting and editing of clinical guidelines. For example, assessment and care of acute stroke in the Department of Emergency Medicine and intraocular injection. Same way, the assimilation of quality and safety trustee activity in both clinical and supportive unit. We use the quality circle model to promote and carry out quality and safety projects. You can see that the first step is a plan phase. Design or revise process components to improve quality. The second step is a do phase. Implement the plan and measure its performance. The third phase is to assess measurements and report the results to staff members and decision makers. And the fourth step is to decide on changes needed to improve the process. And according to this, the team staff decided if to continue to a second quality circle. One of the challenges of every hospital in Israel is to successfully meet the quality indicators of the Israeli Ministry of Health. The objectives of the national level is to improve the quality and safety of care through a system of selected quality indicators in Israeli hospitals. The means to achieve this through a regular ongoing monitoring of national quality indicators from existing database, computerized database, in order to identify compliance to standards and trends over time. Hospital data are transferred to the public and they are published in the newsletter and in the internet website of the MOH. The national project of the National Indicator Project began in the 2030 with 5 indicators, quality indicators in general hospitals. This year, 2018, Hadassah hospitals are coping with about 60 quality indicators of general departments, psychiatry, rehabilitations, infection prevention, and service. This is a huge, complicated, and challenging project, and it's requiring cross-organizational collaboration. In order to succeed in the quality indicators, it is necessary to assimilate new work process among staff members and to improve documentation in the medical file and other computerized systems. I work with administrative and medical directors and head nurses to improve process, as well as with the information system division. In the future slides, you can see some examples where you can see that over the time there is an improvement. Here, for example, is a hip fracture surgery within 48 hours, a national indicator. You can see that there was a period of assimilation and implementation of the indicator, and nowadays we are in a quite good situation. Another example of national indicators is risk assessment of psychiatrists' emergency cases during the examination in the emergency department. Another example is performing nutritional assessment within 36 hours from admission to hospitalization in the rehabilitation department. In every department, there is a quality and safety board with service and audits data and other information regarding quality and safety are presented. I continue to the safety issue. You see, we are now in the safety domain. In the area of safety, we are carrying out safety rounds in the hospital units, as well as medication room safety rounds. We are implementing this as a cross-organizational methodology. Safety rounds are an effective tool in the management and achievement of quick improvement safety. So we are implementing this across organizational methodology. Safety rounds are an effective tool in the management and achievement of quick improvement in safety. performing quality service and safety service and audits of clinical, supportive and administrative units. For example, narcotic control, pain control, informed consent for blood products, fire safety, hand hygiene and isolation. We receive weekly reports from the Ministry of Health regarding safety incidents occurring in Israeli hospitals. In cooperation with the risk management unit, we examine the risk and when necessary, we implement the required improvement. Writing and implementing organizational procedures and standards are another activity. The Organizational Committee of Quality and Medication Error Prevention performs near-miss and adverse events debriefing and promotes implementation of safety improving actions, also designing medication rooms, design of color-coded labels for intravenous high-risk medications and lines, update medication-related procedures, leading of organizational projects such as medication refrigerator, temperature control and documentation, and disposal of pharmaceutical waste. Here you can see some examples of color code labels for intravenous high-risk medications and lines that we designed to promote safer medication administration at the intensive care unit bedside and other acute wards. You can see that there is a dedicated label for infusion bag or syringe, label on IV or feeding line, syringe pump in adult, and in the right picture you can see the macaroni picture. So those labels are, the purpose is to help distinguish between among the different lines. Okay, you can see. And here you can see some examples of color code labels for intravenous high risk, and here you can see some labels for IV feeding lines. The labels were designed as part of the organizational project by the Committee of Quality and Medications Error Prevention, and there are many other hospitals in Israel that are using these labels. Okay. Here you can see some examples of here you can see several examples that reflects implementation of safety standards in clinical wards. For example, containers for drug disposal, cover clean medical equipment in a plastic bag, and cover and a clean suction device with a plastic bag, and help bell pull cord at the appropriate height, 10 centimeters above the floor, so if a patient falls, he can ask for hand help. Okay. Those are examples of safety posters, instructions for patients regarding preventing falls. The posters are translated into several languages in order to make the information accessible to patients who do not speak Hebrew. You see, we translate it even to Russian. Okay, one, two, okay. On the right, you can see the 5 minutes model of hand hygiene, of carried out hand hygiene, and it's hung all over our clinical unit in main corridor, and it's also appeal to patients and their families. Continue. We edit and publish safety leaflets. The safety leaflets are edited by a multidisciplinary team, including nurses, pharmacists, and physicians. In the leaflets are described safety events which occurred at Hadassah. Also described lesson learned, insight, and corrective actions that we carried out. The safety leaflets are sent by email to all Hadassah employees, and they are also presented on the quality and safety boards in every department. The importance of the safety leaflets is that they help to assimilate a safety culture. We appreciate safe behavior of our employees. For example, employees whose managers have recommended them as employees who have demonstrated safe behavior above and beyond receive a certificate of appreciation by the hospital manager at the hospital management forum. Safety round. A multidisciplinary committee promotes proactive safety rounds in hospital units. The activity is conducted through safety rounds. The members of the committee are the managers of the different safety areas in the organization, including the members of Hadassah Hospital Management. I can testify from my personal and extensive experience that safety rounds are a plan at work. The committee is established out the awareness that medical errors and mishaps are often a result of an organizational culture that does not focus on safety in general and on patient safety in particular. Organizations like the ARC and the JCI recommend performing safety rounds because they contribute in identifying systemic safety problems and improve organizational commitment to safety. Yes. The committee's objectives are to proactively identify safety weaknesses and act to rectify them, to promote safety and safety culture in hospital units, to create a mechanism for solving immediate safety problems, and to be an address for appeal regarding safety issues. The hospital unit level is a level at which the majority of patients and care providers meet. Therefore, safety failures and errors exist. The hospital unit level is the most important factor to reduce, stop, or to prevent harm to our patient. Therefore, this is a level to be focused in order to perform significant changes and interventions related to patient safety. The committee members are senior managers in various areas of safety. This has great significance because the members of the committee have the power and the authority to take decisions. In this way, changes are made relatively quick. The committee members jointly conduct the safety rounds with the participation of head of departments, head nurse, and the unit housekeeping supervisor. Our approach is systemic, not punish, encourage reporting and transparency. The rounds includes various of safety issues such as infections, medication, medical gas, electricity, hazardous materials, medical equipment, resuscitation cart, safe storage, fire safety, emergency exit, and more. We use structured tools to different types of units. Okay. The process of conducting safety round is as follows. We carry out first safety round and with one representative of the committee with the unit head or head nurse and is designed to match expectations. Extended proactive safety rounds held with all committee members and post-safety rounds held with one representative of the committee to check whether improvements were carried out. Safety round, limit or extended without prior notifications held with one representative of the committee to check whether improvements were carried out. Okay. At the beginning of each round, the departmental staff asked if he identified safety weaknesses. Therefore, the final report often includes more issues than those specified in the questionnaire. The safety round is scheduled in advance with the department manager. They got the audit questionnaire and relevant procedures in advance. All of the members of the committee and the departmental management team participate in the safety round. The round lasts about 1 or half an hour time. A final report is prepared with a detailed operative description of both unit and systemic weaknesses. The report contains findings, recommendations, and persons responsible for improving and schedule to implement the recommendation. Additionally, the department manager is asked to return a status report to the committee chairperson within 10 days with detailed description of the status of the recommendations that were implemented. Continued follow-up is done on the recommendations that were not implemented in the 10 days report. This is an example of report detailing the weaknesses and strengths according to area of safety. You can see there is the findings, the recommendation, the responsibility person, the schedule for implementation, and status of implementations. Within the framework of the committee, 5 to 7 external safety rounds are performed monthly in hospital units. We do not have the capability to annually audit the entire hospital. However, because the issue is such an important one, it was decided that the quality and safety trustee in each unit will perform audit in his/her department. This makes it possible to perform safety rounds annually in most of the units. Open communication, transparency, and partnership encourage involvement and taking of responsibility for safety by departmental management team as well as hospital leadership. Following are several slides illustrating a number of identified safety weaknesses. For example, equipment blocking both the emergency door and access to the fire extinguishing cabinet. Expired hazardous material cabinet in pathology lab discovered during safety round, and oxygen cylinders that are not stored in a dedicated safety device in internal department. Here you can see equipment storage on the floor. This is prohibited in aspect of infections prevention. All equipment must be stored above the floor height, and a dirty chair made of non-washable material in a clinical unit, in a violation of regulation. Here you can see an old electrical cabinet that is long overdue for a safety test and exposed alcohol sponge and non-standard waste can. A waste can needed to be covered with a cap and open only by foot. Example of applying organizational quality process include, for example, performing an audit of radiation protection shield and thyroid protection devices and writing an institutional procedures on this issue. In addition, a computer program was developed to document the control that were implementing. Dedicated safety medication rooms round are also conducted in all clinical units. In conclusion, we believe that safety rounds represent an effective strategy in promotion of safety and safety culture within the organization. And now a little bit about service and patient experience. In the area of service and patient experience, we implement a Ministry of Health Patient Experience Service to prepare a computer infrastructure for transmitting the data to Ministry of Health and present those service outcomes to relevant departments. It includes survey in general departments, outpatient clinics, rehabilitation, and emergency room. You can see an example of patient satisfaction scores. We conduct also internal satisfaction survey. Hadassah is making an effort to make medical translation service available to non-Hebrew speaking patients, a factor which is known to be essential for patient safety and positive patient experience. Hadassah has a contract with the Professional Medical Translation Center, subsidized by the Ministry of Health in Israel. We also operate volunteers who undergo special training for medical translation face-to-face. An organizational effort is made on our regular basis to assimilate the use of those medical translation services. Here you can see roll-ups and cards in several languages at the hospital patient reception office, used to encourage patients to use this translation service. Posters are presented in every physician and medical staff room in every department to encourage the use of translation service. An organizational campaign was another tool for assimilating the use of translation service. Another aspect of promoting safety and patient experience is patient education. An effort is made to edit patient information leaflets as medical staff utilities in patient education. You can see some examples. Hadassah also has a website portal of patient information leaflets open to patients and public. And a few words about organizational learning. Promotion and development of organizational learning are essential to establish an organizational culture of quality and safety. Following our example of activity running at Hadassah. A departmental quality and safety management workshop for department head and head nurses will be opened in October and will be run on a regular basis for the training of all managers in the organization. Adverse event debriefing workshop to multidisciplinary staff, management of safety training for the various sectors according to their professional needs. For example, laser safety, MRI safety, fire safety, and conducting Ministry of Health educational software on safety care by Hadassah employees. Activities, materials, and information on quality, safety, patient experience, and JCI accreditation are presented in Hadassah Quality Portal. Publishing lessons learned and activities conducted to improve safety via Hadassah Safety Bulletin are published every month. And installation of plasma screensaver in medical staff computers cards in the clinical units with safety message. And one before last, JCI accreditation. It's my last slide. Hadassah is currently in process of implementing JCI accreditation standards. We are adjusting our procedures, work process, and facilities to the JCI demands, and I hope that very soon we will be with this accreditation. So in conclusion, these were some examples of organizational activities in general hospitals to promote and improve quality and safety for the welfare of our patients as well as our staff. Thank you. If you have questions.
Thank you very much, Doctor. Have you a question, please?
Okay, thank you.
Hello, National Association of Medical Informatics, Konstantin Chibatayev. A couple of questions. You mentioned the national program for safety. Did you play any part in preparing it? And how long was it in the making?
As a national indicators,
The National Program for Safety, you mentioned it on one of the slides. It's on one of
yes, to
yours.
you.
National Program for Safety?
Oh, yes,
Yes.
we have
How long?
an educational software about some issue regarding safety, and every employee in Israel, in Israeli hospitals, have to do it.
Mhm. Is that a guideline or is it enforced?
This is a guideline. It give a background about what is safety in medical organization, how employee can be involved in such activity, and what is how can employees can be involved in promoting safety in the hospitals. This educational software is adjusted to physicians. There is a different learning softwares adjusted to physicians, to nurses, to social workers, to housekeeping. There are different modules, and every sector has the unique points relevant to him.
Wait 1 second, I would like to add. In general, in Israel, the Ministry of Health has passed legislation forcing all hospitals to cooperate. At the beginning with quality, so we must turn all of our quality data to the ministry. We do not have an option not to do so, and then it's publicly publicized by the government. Second, regarding safety, there are a list of safety events where we must report directly to the ministry in 24 hours. And the ministry itself would occasionally also would nominate a committee, an investigation committee, even for specific safety event in a specific hospital. So as we are a small country, the ministry could be quite involved also in particular events that we do see occasionally.
Thanks, I appreciate it. The last question. The safety reports. You do the rounds, you consolidate the report, then you analyze the report, then you implement the changes. That's all workload. Is that done at the expense of the existing workload, or is that compensated extra? So do they pay you for doing the safety?
No.
No? Or is it dancing out time already taken by other procedures?
It's always an argument between us and our employees. They want to get more bonuses or extra hours, and we say that we don't have the money and they should do it as part of the job. So it's a game.
Thank you.